So you get a report on this patient who recently had a stem cell transplant. You find out he's been pooping all night long, like a massive amount of poop. And then you see his skin and it looks just so angry and upset and like almost sloughing off. Were any red flags going off yet? Or are you still just thinking, oh my gosh, this poor guy and his diarrhea?
Hey there. I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response RN podcast. I'm your host, Sarah Lorenzini, and today we're diving into a really important and often under-recognized complication of stem cell transplant, and that is graft versus host disease. I'm joined by Anthony. He's a rapid response nurse from Canada who's going to share a case about a patient who developed graft versus host disease, or GVHD, after undergoing an allogenic stem cell transplant for leukemia. So we'll walk through what happened, what graft versus host disease is all about, how it shows up at the bedside, what the treatments are. The conversation is going to blend real-life critical thinking with the pathophysiology pearls so you can take them straight to your practice. So without further ado, Anthony, welcome to the podcast.
Yeah, so thank you for having me. This is a great, I love seeing your podcast, and I'm just honored to be on it. Thank you for having me.
And we've been friends for a while.
Yeah, I know. It's been a while.
You being a rapid response nurse, it's so good to actually have you on the show finally. This is great.
It has been.
So before we get to the case, will you just introduce yourself, share a little bit about your background as a rapid response nurse in Canada? Yeah. You guys call rapid response team something different than we do here, right? What do you call it?
Yes, we call it CCOT.
Okay.
Or sometimes CRT, but so it's Critical Care Outreach Team. So I think it works a little bit differently too. So I'm not always the critical care outreach team. I'm not always that. I'm usually sometimes on the unit, sometimes on that team. But it's always a critical care nurse, usually extra trained. And then we get on our shifts, we see when the next CCOT shift is. And so how it works, we'll typically have like a roster of patients that we're following. Usually it's patients that have been discharged from the ICU, or patients that we got recently called on, and then we follow up. And sometimes the list can be like 10 to 14, sometimes longer. But yeah, that's kind of what a typical day is, I guess.
Okay. And how long have you been a nurse?
Total has been about 14, going on 15 years. So I haven't been just in critical care. So I've started in oncology first 2-3 years, went to ER for 3 years. I did surgery, did a little bit of community, and now I've been in critical care for the majority is almost 8 to 9 years.
Okay. And then how long do you have to be in critical care to be chosen as a CCOT nurse?
So when I started, because I had the ER background, I kind of got into it a little quicker, but typically it's about two or more years.
Okay. Gotcha.
They kind of see how comfortable and how well you do on the unit first.
Okay, cool. So as a CCOT nurse, what types of things do you do all day long?
Yeah, so we have a criteria. So it kind of goes through the ABCD of criteria where a nurse will call on the unit, one of the units, and they'll say, I know we have heart rates, 40s, maybe decompensating. Can you come and see them? And we'll go up. We have a medical directive to say, okay, for these conditions, we can do EKG, X-ray. I can order these type of labs. We could even ask the RT to poke them for an ABG, since we don't do ABGs. So yeah, it's a lot of autonomy. What will happen is that we get the call, we go to the patient, we do our kind of ICU assessment. We ask the nurse, get a little history, what's going on. We do a medical history of the computer too. And with our findings, and kind of wait for labs and stuff to come back, we'll call the doctor and tell them, hey, this is what I'm thinking. Should we go into ICU? What's their code status? Did you address code status? Or are they good to stay on the floor just to monitor them for the next couple of days?
Okay, yeah, I love that. I also like the name of your team too. I think people think rapid response team. They just imagine me like running from one code blue to the next all day long.
Yeah.
Or then I'll show it to a patient's room who is stable and say, hi, I'm Sarah. And the rapid response is like, oh my gosh, who's this chick with the backpack and the fanny pack? It's kind of scary,
Right. Yeah, for sure.
If I could just say, I'm the critical outreach team, it's like, oh, okay, the ICU's outreached to the floor and they're here to support the bedside nurse. Yeah. And it seems a little less daunting,
Abrasive, yeah, I get it.
And also a pretty clear description of what you do. You are literally outreaching to the whole hospital as a critical care resource. I love that.
And we have a cart, actually. We have a cart that we don't have a backpack. It's a cart that it's almost like a code cart.
Okay.
So we travel with that cart all the way around.
What color is it? Is it red?
It's like blue and some red, like medical towels. Yeah.
Oh, darn it. I was hoping it'd be red.
I love
all
red.
of our crash carts in the States, at least, are red. But okay, blue.
Oh, okay.
Blue's pretty cool, too. Okay, let's dive into this case. So I know it's been a bit since you actually had this patient.
That's been a bit, yeah.
So I know it's hard to understand the details, but can you just take us back as best you can remember to this patient? What were you told in report? What did you see when you did your initial assessment of the patient?
Yeah, for sure. So from what I remember, this patient was about 45 days post allo transplant. He was about in his late 60s, diagnosed with AML. And so prior to the allogenic transplant, you get high dose chemotherapy. And so it just kills all your cells so that you're able to qualify. And if you do well with that, you qualify to get this allogenic transplant. And here where we are, we don't do the actual allo transplants. They actually go to London, stay there for a bit, and then they come to us to kind of, because we're close to home. And so, yeah, so it was about 45 days. And I think this patient also had some GERD. Maybe they were treating him for pneumonia as well. And I will never forget, the night shift had a horrible night with them. They were having diarrhea nonstop. It was, honestly, the list, it was like pages. I just remember, I think it was probably a few days, but just for the night, it was probably 7, 8 bowel movements, maybe more.
Wow.
And then that's kind of how it started. And then just going to see the patient, honestly looked like, just the skin was just horrible. He was, losing all his hair, and being a newer nurse, I was like, whoa, like I've never seen this before. So yeah, he had a diarrhea, but also we have to be very cautious because of so much diarrhea. Poop, you potassium. That's what I think of. Poop, potassium. So you lose so much potassium. And so you're at risk for, cardiac events to happen. Like he was on the commode so many times, and the amount of pain, like from just his skin being so sensitive, it was just horrible. It was really a sad case. It was tough for him.
So you get a report on this patient who recently had a stem cell transplant. You find out he's been pooping all night long, like a massive amount of poop. And then you see his skin and it looks just so angry and upset and like almost sloughing off. Like, what were your initial concerns? Had you seen a patient before with graft versus host disease, or was this your first encounter?
This was my first encounter.
Okay, yeah. It can look pretty gnarly, for lack of a better word.
Yeah, exactly.
Okay,
it can.
So were any of the red flags going off? I know you're new, so if this is your first time seeing it, were any red flags going off like, oh my gosh, diarrhea plus this horrible rash with the skin sloughing off, recent stem cell transplant? Like, were any red flags going off yet? Or are you still just thinking, oh my gosh, this poor guy and his diarrhea?
At first, yeah, it was just the poor guy diarrhea. But then I'm like, okay, I think we had him on antibiotics for pneumonia. So I'm thinking, oh, maybe C. diff.
Right.
That type of thing. Because he's so much diarrhea. We do send a sample for that. But yeah, I didn't know what I was dealing with, honestly.
Yeah. I think that's a common assumption actually is that if we see diarrhea in a patient, we're going to think, okay, all these antibiotics are messing up their GI tract. Like that actually happens a lot.
Exactly.
It happens more often than graft versus host disease happens. So yes, I've been thinking that too.
Yeah, that can kill people too. So
yeah, okay.
Yeah, for sure.
So, and then what other concerns are you having, or what other diagnoses were you guys doing as you're trying to figure out how to help this poor gentleman?
So yeah, later on we figured it. So another thing that can happen is cytomegalovirus. So CMV colitis can also be one of those symptoms that after a transplant. And so, is it that? Is it, C. diff? Is it that? Because sometimes you get, radiation to that area, or so is it like a type of, it's like an irritable bowel because of the medications we gave him?
Yeah. All possibilities.
Yeah, there's a couple of kind of differentials I was thinking of on top of, I didn't think right away that GVHD I knew it was there, but I didn't come up right away until, the team. So we had a consult, obviously, like the gastroenterologist. We had hematology already on the unit, so they've been following already. And, to pick their brain a bit, that was kind of their differential. Okay, yeah, it could be this, use 45 days post-transplant, post-allo transplant. So the best criteria for acute graft versus host disease is, the gut, the skin, and then having within, I think it's less than 100 days. So if in that window, it's like acute, and then anything above that is like a chronic, like graft versus host.
So for nurses that maybe don't care for this patient population very often, can you just break down what's actually happening with graft versus host disease, and then why does it happen after an allogenic stem cell transplant?
Hey nurses, I know a lot of you listening work in critical care, the ER, or other acute care settings, places where emergencies can unfold at any moment. And if you've ever wished you felt more equipped to handle those situations, or if you're already experienced but want to take your skills up to the next level, you need to check out the Winter 2026 cohort of Rapid Response Academy. This is a 10-week high-impact training program built for nurses like you. You'll master the science, advanced pathophysiology, critical thinking, evidence-based interventions for shock, sepsis, cardiac arrest, strokes, and respiratory failure. But just as importantly, you'll strengthen the softer skills that make or break you in a crisis, like leading with calm in the chaos and advocating for your patient and navigating those tough conversations with the interdisciplinary team. So whether you're a brand new nurse finding your footing or a seasoned nurse ready to refine your expertise, Rapid Response Academy will give you the confidence and clinical edge to thrive when pressure is the highest. Pre-sales start February 9th, and we kick off our first meetup of our 10-week course Friday, February 20th. To learn more, I put a link in the show notes for you. Okay, back to the episode.
So GVHD happens when donor immune cells, so mainly the T cells from stem cell transplant, they pretty much attack the host body. So it's almost like a reverse autoimmune where you're trying to get the good cells from the allogenic transplant, but instead they're attacking your own body. And so because your GI tract and skin replicate a lot more than the other cells in your body, those are typically the areas where the GVHD kind of attacks.
Gotcha. Okay, so with the GVHD, you have this immune response. There's this inflammatory reaction. All these cytokines are released. How do we handle that? What do you do about it? Obviously, cream for the skin and replace the electrolytes for the dehydration and the fluids. But what else can we do to treat someone who has GVHD?
A lot of it is supportive care. One thing I didn't really think about was, they've just gone through, horrible chemo to get this allo transplant. And now they're going through this horrible disease, losing their skin, tons of diarrhea, skin management. You want to make sure you prevent a secondary infection. On top of that, you can get, bleeding from such erosion from the diarrhea. And so a big part is definitely supportive. Another part is, which I think is really important now, is, handling their mental capacity, their mental health, really. Because they're going through hell. They're going through hell. Not only how they look, but how they feel, the pain. Is this even worth doing anymore? And so those conversations you really have to, be comfortable with. And that population too, he's 60's not that old, really. But he's an older man. And he's gone through all this, how much more is he going to do? And so really the supportive care is we've had patients like this and you can get through this. You're getting the family involved, getting, even social work. We're very lucky where we are in Windsor to have, social work pretty much right in the rooms to be there for the patient where like we have multiple patients. So it's really a big supportive thing you do on top of, steroids and, antibiotics to try and help the gut. Really, that's kind of most of what we do.
Yeah. I think you're spot on in pointing out that our role is kind of like twofold. Yes, we need to support their electrolyte balance and their fluid volume balance and, take care of their skin. And obviously steroids is like the mainstay of treatment for graft versus host disease. Mm-hmm. But that's just like the medical side of it. That's the science interventions. There's this whole other aspect of nursing, which is like the art of nursing or the heart of nursing, whatever you want to call it. The beauty behind what we get to do. And that is recognizing that, yes, I can give all the right treatments. I can administer all the meds on time in the correct way. Mm-hmm. But if the patient is just like falling apart emotionally and doesn't even want to keep going, there's more care that needs to be provided besides just what's on the MAR,
Oh, for sure.
And so recognizing our role of like checking in with the patient and helping them process all this and trying to bring some hope. And like you said, telling them that other patients have been through this and have come out the other side and I've seen them survive and, gathering the family around them and getting social work on board and all of those like interdisciplinary, like family involvement, all those things are just as valuable as getting the meds in the patient's IV on time,
Absolutely.
And so I'm so glad that you
100%.
spoke to that and not just like the science intervention. There's more to it besides just what we have head knowledge-wise. There's so much more to it. That's a really good point. There's one other point that I wanted to make. I know that with graft versus host disease, it can be acute, like in your patient, but it can also have more of a chronic presentation too. How are the two of them different? Like how can we differentiate the two? And then is the treatment any different or what is the nurse's role any different in managing acute versus chronic graft versus host?
Yeah, so acute versus chronic, an acute graft versus host usually happens within the first about 100 days after transplant. It's more inflammatory with the skin, gut because of that quick cell turnover. And with chronic GVHD, it happens later just after the 100 days. And it's more an autoimmune, like you get fibrotic features like sclerotic skin, mouth and eyes, dryness, even some lung scarring. So thinking of, in ICU terms now, if you're having this lung scarring, knowing that history, when you intubate them, they're going to be difficult to ventilate. Mm-hmm. So that's kind of the main differences between the two.
So when you reflect back on this case and maybe other patients that you've encountered that had GVHD, what would you say are like the primary pearls or takeaways that you would want to bestow on, say, a newer nurse who's never had this patient before? Like say you get called to a rapid response and there's just like, my patient's skin is sloughing off and they're pooping like crazy. Like, what can I do for this patient? What would be the things you'd want them to know about how to care for this patient, what your priorities are?
Yeah, so even like for teaching a new nurse. So nurses are the eyes and the ears of the bedside, right? So we're the first to notice small changes like stool volume, like he was having so much stool, rash spread or even jaundice. So documentation is key. Recording the extent of body surface area, like taking even photos. Some facilities are able to take photos and document, okay, I'm noticing some changes here. Is this graft versus host? And even getting the other team members involved. Like, hey, what do you think? Or, letting the doctor know, but like, hey, I'm noticing you're having pain in the mouth or when they have stool and the amount of stools they're having. So we can monitor even the effects of steroids, blood glucose, mood changes, and signs of infections. So you can't get a secondary infection because your immune system's so low that you're, high likely of getting another infection. So, and you want to keep track of the stools because you want to make sure they're hydrated. So, and keeping track of all the electrolytes. So really, it's those subtle changes of, okay, he's having lots of diarrhea. I know, is it C. diff? Is it like cytomegalovirus? But you definitely you just had an allo transplant. Let's look into, okay, graft versus host. Let's keep that on the radar for sure. We thought, and because they could have C. diff with graft versus host. And so you could be treating both of things. So definitely, being diligent in your documentation, how many stools, what type of stools they're having. Is it loose? Is it solid? All those little things that you don't like, oh, it's just like, oh, you're just having poops. But we really have to know even like in the descriptions, it says, is it stringy like, or is it, does it have granules? Like all those little details are important to note.
Good. So, and then that's just like recognizing and like having the red flag of this could be graft versus host. And then what about once we do have the definitive diagnosis? Yeah, this is what we're dealing with. What are the priority interventions for managing this condition?
So a big thing would be, is that, again, like we said, this is a steroid, the immunosuppressive, and the supportive, where, we try and boost their immune system as best as possible to really take on that allo transplant and to kind of guide them through this condition until, the end, because it is a long course once they do have it. So it could be, the acute's less than 100 days, but again, a chronic could be up to maybe even a year, depending how they're managed. So it's really preparing the patient too for such a long kind of journey through this course.
That's good. That's good. Well, I think this was a really great case, Anthony. Thank you so much for sharing it with me. This is such a complex condition, but hearing it through a real patient story kind of helps it stick. Thinking about that patient that you encountered and the empathy you had for him, seeing his skin in such terrible condition. So for our listeners, when caring for post-transplant patients, always keep graft versus host disease on your differential. If you see these unexplained rashes, diarrhea, liver dysfunction kind of coming out of nowhere, worsened respiratory status, all these could be clues that the graft versus host disease is popping up. Early recognition and collaboration with the transplant team can make all the difference. Before I let you go, Anthony, I did want them to hear about your app that you're building. Can you just take a moment to explain, first of all, why you're building an app and then what it is?
Yeah. So the big reason being on the CCOT team has taught me that newer nurses, even seasoned nurses, having some support was like such a huge difference. And now working the CCOT team, going to one of the calls and giving them the knowledge to be like, okay, I have these symptoms with my patient. What can I do? What are the tools in my toolbox that I can use to really help this patient?
Yeah.
Because oftentimes I'll go to the call and be like, oh, you have this on your MAR. You have this, this, and this. You can give them this. And they're like, oh, geez, I didn't even think of that. Like, I didn't know that was used for this. And so it's more of an educational tool, but also does real time. You can do your ABCD, how's your airway, how's your breathing, how's your circulation, and you all type it in and it gives you things. So, okay, did you look at their CBC? Are they anemic? Did you look at, the potassium? Did you look at, different things to just keep you kind of on the ball and be like, okay, I looked at these things. I still don't know what's going on. Okay, now it's time to get the bigger guns in and get this call CCOT. Let's call my doctor and be like, hey, these are my concerns. This is what I've done. These are my labs. And I really have a full picture of the patient. Yeah. And so that's why I started building this app. And I really wanted to help as many nurses as possible to be educated, but also to help their patients and to avoid ICU. And this is the goal, right? Yeah. So that's really why I started this project.
Awesome. So what is the app called again?
So the app's called Rapid RN.
Love it.
Yeah, it should be released hopefully soon. I have some people trying it out, testing it out. So if you're interested in testing it out, please send me a message. We'd love to have you. But
awesome.
Yeah, it's been a great journey.
So the bedside nurse, how would they use this like in real time? They're at the bedside, they're caring for a patient, they have concerns, they bust out Rapid RN app on their phone. How do you see them utilizing this to provide the best care to their patient? Yeah,
so the way I kind of envision it is their patients, they're concerned about the patient. They look at their vitals, blood pressure's maybe on the soft side, 98 over 50s, but something's off. They just have that, that nursing gut feeling. And so they can type in it kind of prompts you. So you can go through, your ABCD and then using what knowledge that I've put into it, plus the knowledge of some AI power into it, it gives you a list of things to be vigilant about, where you are kind of ahead of the game, where you've checked all these things. And now you have a tool to kind of back up what concerns are. And it gives you that, almost in this way, it's like a security. You say, I was feeling off about this patient. Mm-hmm. And these are the reasons why.
That's good. It sounds like almost like a SBAR support tool.
It is, yeah.
And at least in that aspect of it, right?
It does have that, yeah.
Because you can put in the situation, you can put in the background. It tells you, here's the things you should be assessing for if this is the case.
Yeah.
And maybe here's some things you could be recommending if this is the case. It's like
Exactly.
it's a resource to help you kind of think like a seasoned nurse who's seen these cases before and be able to advocate with more data besides just, hey, doctor, my patient, something's off, which that's valid. Yeah. That is a valid thing to say.
That's valid too.
But when you can say something's off with my patient and I noticed that this is trending in their labs and I noticed that their respiratory rate has gone up from 12 to 26.
Exactly.
And you're like giving all the valuable data that should, red flags in your doctor's head to say, oh, okay, maybe I should order this diagnostic or maybe I should just come to the bedside, And so, I remember being a new nurse and knowing something was wrong, but just not even knowing what to investigate further to figure out what was wrong. I just knew my gut says something's up. So what a great tool at the bedside in your pocket that you can bust out to help you take the best care of your patient. So yeah, I think that's wonderful.
Exactly. It really pinpoints kind of what's going on. So gives them that direction. So I think exactly what you said.
Awesome.
For sure.
Well, I will put a link in the show notes if you guys wanted to check it out for sure. But Anthony, thank you so much for your time today. I know you just got out of class and you rushed home to record this episode. So thank you so much for making time for me. Thank you everyone for tuning in to Rapid Response RN. So if you've enjoyed this episode, please share it with a fellow nurse. Make sure you're subscribed so you don't miss the next one. Anthony, again, thank you so much. Until next time.
Thanks so much. See you for sure.
Stay curious, stay prepared, and keep looking past the task of nursing to see the human soul that you've been given the opportunity to care for.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as The Rapid Response RN.